Hello friends, welcome back to Endo Tales from Life. In this video we are going to see one of the most requested and awaited topics of recent time. There's a lot of people have been asking me to post a video on the bioceramic obturation technique. The common question that has been asked to me is the bioceramic obturation technique any different from the traditional sealer and GP obturation technique? The answer is yes, they are slightly different because this is a sealer based obturation technique where the sealer volume is going to be more and the GP is merely going to act as a carrier, whereas in the traditional methods we are always being taught to use a lot of GP and reduce the sealer volume in the final obturation. So the second common question that is asked is it possible to see lateral canals getting filled with the bioceramic obturation techniques, and how do we achieve that? So both these questions are going to be answered in this video. So without wasting much time, let's straight away go to the clinical video.
This is our fifth tale, and I can easily say that this is the most exciting episode so far because this is about the most happening topic in clinical endodontics right now, that is bioceramics. And also this video has a lot of simple demonstration in an interesting and in a story format, in a simple understandable way about how I incorporated the bioceramic technique in my practice and also how I improvised on it little later. So the disclaimer is that I do not have any conflict of interest towards any of the products shown in this video. In fact, all the products that I have shown in this video, I have purchased it myself to demonstrate, and I have just picked it up from my clinical usage. So in my previous endo tale, we have been talking about the theoretical aspect of different sealers and how bioceramics slightly stood apart from the traditional sealers. So in this clinical presentation, let's just revise a little bit of the previous endo tale. So as I told earlier in my previous video, we know that in the traditional obturation technique with conventional sealers, the emphasis has always been to increase the GP volume and reduce the sealer volume. This is because the sealers do not have all the properties of an ideal sealer. So over the time these sealers can disintegrate, and hence we have been taught to do different thermoplastic techniques to increase the volume of GP and decrease the volume of the sealer. But do we achieve what we desire? In spite of we doing thermoplastic techniques and seeing nice radiographs, post-operative radiographs, what really happens is that the sealers, the conventional sealers, be it epoxy resin based sealers or the zinc oxide eugenol based sealers, they do not chemically bond to both dentin and the gutta-percha, and hence there is a marginal gap over a period of time. So this has been proved with studies, and as you can see in one of the published articles, this is an SCM image which clearly shows that the GP and the sealer do not adapt to each other, and the same way this AH plus sealer here does not adapt to the root dentin. Though we know that AH plus has a good penetration, it also has good bond strength, but over time this is just micromechanical interlocking and there is no chemical bonding, or there is no close adaptation between the sealer and dentin, and also between the sealer and GP. So the bioceramic technique is a complete different concept from that of the traditional obturation method, because this is also called as the hydraulic single cone technique. Though we call it as a single cone technique, it's not inferior in terms of the obturation technique because this is basically a sealer based obturation. So the gutta-percha point here acts merely as a plugger. So it's used to push the bioceramic material and condense it nicely inside the root canal, but basically it is a high volume of sealer based obturation with GP merely acting as a plugger. And also the GP is essential here so that later there might be a question that is retreatment possible in bioceramic obturated teeth. So the GP that is being placed acts as a pathway for retreatment if at all is required in the future. So the advantages of these bioceramic sealers is that they have certain properties that none other sealers have in the traditional sealers. So now one is it's hydrophilic. We all know that epoxy resins is hydrophobic sealer, and we know that dentin substrate is always with moisture. It has a lot of water, both the dentin tubule, the intertubular dentin, the everything has water, and hence the sealer wettability is definitely reduced here. But whereas these bioceramic sealers are hydrophilic, so the initial adaptation and contact angle is much improved with the help of these bioceramic sealers. And these bioceramic sealers are dimensionally stable once it sets, which has been proved in many studies that in follow-up radiographs, these sealers do not get washed away like how the traditional sealers are. And these sealers have these antibacterial properties which has been pronounced till the time it sets. So some of these pre-mixed sealers have this antibacterial effect up to 4 weeks or 6 weeks. So this is like a calcium hydroxide dressing. Whatever advantages that we used to get with the calcium hydroxide intracanal medicament is also obtained with bioceramic obturation, where the antibacterial effect is prolonged even after obturation for certain weeks or for a few months. And it's highly insoluble once it sets, though the initial solubility is high. After the sealer sets, it's completely insoluble and much stable. And the most important property is its bioactivity. When it interacts with tissue fluids, it has this ability to produce hydroxyapatite. So that is why we get what is called as intertubular mineralization and a very close adaptation or a chemical bond that happens between this sealer and root dentin. Now we know that this sealer can have a chemical bond to root dentin, but what happens when the sealer and the traditional GP is used? That is why they have come up with bioceramic GP, where we have these bioceramic particles impregnated in the gutta-percha cone. So these GP points are actually not expensive. Now a lot of brands are coming up with this bioceramic GP, which is almost the same cost of the traditional GP points. So we get this in standardized and also non-standardized sizes. So these bioceramic GP have to be used so that my sealer does not chemically bond just to the root dentin but also to the gutta-percha point. So this is what we achieve, where the sealer bonds both to your root dentin and the gutta-percha. So this is a study published in the year of 2019, and you can see that in this study they compared the bioceramic sealer and epoxy resin based sealer on their adaptation and their micro leakage also. And this is the SCM images from the study. They also tested this adaptation over a period of time. Immediately, that is 24 hours after your obturation, 7 days after your obturation, and 4 weeks after your obturation. You clearly see that these bioceramic had a much better adaptation, especially with time, which means that once the sealer is setting and once there is bioactivity happening, these sealers adapt in a much better durable way than the traditional sealers. So coming to the clinical point of view, now which bioceramic sealer should I choose? So basically the broad classification is that you need to know there are two different forms in which bioceramic sealers are available. One is called as the pre-mixed form, which is in an injectable syringe form, or you have this mixable sealers where you have the powder and liquid separately, which you need to mix before usage. So some of the most popular injectable or pre-mixed calcium silicate based sealers are these. The endo sequence is considered to be one of the most famous sealers, which is also marketed as iRoot or Total Fill in Europe and US. And unfortunately, this is not available in our country, in this part of the Indian subcontinent. But what we also have is EndoSeal TCS. This is an improvised version of the original endo seal MTA based sealer. This is a calcium silicate based sealer, and this also is soon to hit the Indian market. So what is available right now is one fill MTA, which is also a South Korean based company, and the Cerasil from Biomed. So these are the different options available for people who are practicing in different parts of the world. In the future, there are even more brands going to set into the market, but you need to know that these sealers come under this category called the pre-mixed injectable sealer. So whichever is available in the place where you practice, you can go for them. The other category is mixable bioceramic sealers, and to my knowledge in India these are the two different brands that is available. One is BioRoot RCS from Septodon, and the other is the Mark sealer, which is also called the Cerasil B. Do not get confused between Cerasil and Cerasil B. Cerasil from Biomed is an injectable sealer, whereas Cerasil B from Mark is a mixable sealer, and this is a powder liquid form. So basically this powder liquid form has a much shorter setting time, so also has a very lower shorter antibacterial action. So now let's go into the actual clinical bioceramic obturation technique. So the first thing, the big good news for us is that for this obturation technique you don't need high-end obturation gadgets like your backfill and other things. So this is not a GP based obturation, and this is a sealer based obturation. So I don't need these obturation gadgets. Instead, I can just go for a traditional hydraulic single cone technique. So I told you that I'll also share some things from my personal life, how I improvised on this bioceramic technique. This is one of the cases which I treated. Is an interesting case because this patient, the first molar on the left side, I happened to treat almost 6 to 7 years back, and back then it was Sealapex, a calcium hydroxide based sealer that I had used. You can see that there was lateral canal that was filled at that point of time. I can see the sealer slowly disintegrating, but clinically the tooth is successful, and I happened to treat the second molar of this patient, and this patient also happens to be the sister of one of my student, Dr. Sujita, who happened to do her undergraduation in Madurai. She was my student, and then she also worked in my practice for almost 2 to 3 years, and later she moved to South Korea and she did her post graduation in one of the prestigious institutions where they work and they develop a lot of bioceramic sealers. So when I had a personal interaction with her about the voids that I get with my bioceramic obturation, she shared me a nice article that was a research work that was done by her professor. So this article by Dr. Kim is on a practical clinical technique to improve the bioceramic obturation without voids, and also to enable us push the sealer into lateral canal. Because the big question that might rise among you is, when we do thermoplastic obturation technique, we know that we can push the sealers into those anatomies and ramification. So is it possible to get that with this sealer based obturation? The answer is yes, with a very simple and effective clinical technique without any high-end gadgets. So this is the clinical recommended technique by Dr. Kim, where they place the sealer in the root canal, and followed by that they just use the GP point to agitate and create some current in the sealer, enabling it to flow into the intricacies. So they hold the GP point with the tweezer and then do some indirect activation with an ultrasonic tip, the conventional scalers that are available in your chair. Turn the water off from that unit and place that on the tweezer holding the GP, so that we transfer indirect ultrasonic activation to the GP point, which is going to push the sealer into the intricacies without creating a mess. We all know that when we use lentillo spirals or when we use ultrasonic to directly place sealer, it pushes a lot of sealer beyond the apex, which is not what we want. So this is a very simple conservative method of achieving this. So this is what we do. We basically hold the GP with either a locking pliers or conventional tweezers, and then I place my ultrasonic tip. I ask my assistant to place my ultrasonic tip onto my tweezer, and when I slowly insert the GP into the canal which has been coated or which has been filled with sealer. So I would teach you two different techniques of bioceramic obturation technique. Number one is the advanced technique, which I really recommend only for people who use magnification. The other one is a basic technique which others can follow. So the preliminary steps are the same for both the techniques. We select a master cone that fits snugly at the working length. And following this, I need to dry the canal, and here it's slightly different from how we dry the canal for the traditional epoxy resin based sealers, where I need complete dry canal. They even recommend using ethanol to desiccate the root dentin, but that is not required when we use the bioceramic sealer. So what they recommend is a single paper point drying. So just place a single paper point, leave it there for 10 seconds, and the remaining moisture is okay and in fact needed for the sealers to set. So this is the advanced technique where I directly inject the sealer into the canal. So I make sure the sealer comes to the tip of the cannula so that I don't inject the air that is present in the cannula inside my root canal. So extraordinarily, I make sure the sealer is pushed till the tip. I just place my cannula to the middle third, not to the apical third, and I slowly inject. This is why magnification is needed. I slowly inject and also withdraw, making sure I just fill the sealer to the middle and coronal third. Now following this, I will take my selected master cone, hold it with my tweezer, and then this is how I'm going to do it. I will place my ultrasonic tip over my scaler, over my tweezer, so that I do indirect GP mediated agitation or activation. So see here, I'm slowly placing my GP inside the root canal, and as I do this, my assistant will keep the scaler tip onto my tweezer, and this is going to give me some indirect activation, and you can see the apical puff of sealer that I'm getting. So if we have lateral canals, if we have some white canals, if we have some intricacies inside the root canal, the sealer is going to flow into all of those spaces. And following this, you can use any traditional or modern gadgets to just shear the GP at the orifice, and then I use a cold plugger to condense the GP at the orifice or 1 to 2 millimeter below the orifice. And that's it. We are done. So this method, you get a complete fill of all the spaces without using these high warm vertical pressure. There are studies which have shown that even warm vertical compaction can cause root fractures. This is a passive technique and is called the hydraulic single cone technique. So let us see the same thing in a clinical scenario. In my previous one of my endo tail, I told you I always leave behind a little bit of caries on the proximal margin initially so that my rubber dam doesn't tear. I don't want any bleeding. So in this case also you can see here, those caries will be taken care of later. Now I'm going to proceed with my obturation, and as I told you, we are just going to use a single paper point to dry the canal, and following that I'm going to inject my premix sealer from the coronal to middle third, then place my master GP, hold it with the locking tweezer, and my assistant is going to place the ultrasonic tip over to my scaler on my tweezer, and this is going to give some indirect activation to the sealer, enabling it to flow into all the intricacies. Then I use any heat source to just shear GP at the orifice. Following that, we use a cold plugger and push it and condense it. That's it, we are done. So, do we get lateral fills with this technique? The answer is yes. In fact, when I used to have some chat with some of my friends, they were little skeptical because they were all fans of AH plus. We know that AH plus is nicely radiopaque. When it flows into the lateral canals, it's very nice. So when we show it to our colleagues, our cases, we feel good to see the lateral canals on our post-operative radiograph. And let me tell you that there is some good news. The bioceramic, especially the premixed form, is seen in the post-operative radiograph. It can flow well into the lateral canals and is as radiopaque as AH plus sealer. And this was one of the challenges. These are the cases where I slowly got completely convinced, and I also felt that it is worth it to completely shift to bioceramic technique in my obturation. So this was a failing root canal treatment that was referred. I had to do endo. I was surprised that there was a deep apical split, and believe me, this case was obturated with the simple hydraulic single cone technique. There was no warm vertical compaction done at all. We have used the same way. We have injected sealer in the canal, used a GP point, indirect activation, followed by that we have done this. So extreme anatomies that were earlier thought to be obturated only with the help of downpack or warm vertical compaction can be easily filled even with the bioceramic technique. But why do I recommend this advanced technique only for people who use magnification? This is one of my colleague when this doctor did the advanced technique of directly injecting the sealer. When you don't use magnification, you don't have a control, you don't know whether the cannula is expelling the sealer. At times you tend to over inject, and in this case you can see the amount of extrusion of the sealer that has happened. So luckily there is no nerve structures that are apical in this area. So we do not recommend, even if it's a bioceramic sealer, it should not go beyond the apex. So there are incidences where case reports where bioceramic extrusion into the mandibular canal can cause paresthesia. So we need to make sure our obturation is always restricted to the apex. So what is the basic technique then? In the basic technique, this is what I recommend for people who don't use magnification. You can take the same injectable sealer and remove the cannula or remove the cap. Just dispense a little onto a paper pad. And following that, you can just use your GP point, coat a little of sealer in the apical end at the tip. Just use your GP point like a paintbrush. Repeat this at least 4 to 5 times till you make sure there is adequate sealer in the canal. This is a passive way to avoid excessive overfills and everything is under control. So we keep repeating this. In the traditional single cone with AH plus, we don't recommend coating this much of sealer because there I don't want my sealer volume to be high, but here we are intentionally placing a lot of sealer and less of GP. And after this, you can do the same thing here. GP mediated activation. I hold my GP point with a tweezer and my assistant is going to place the scaler onto the tweezer, which will enable the sealant to flow into the intricacies of the root canal system. And following this, you can use any heat source to shear the GP at the orifice or 1 to 2 millimeter below the orifice, and then use a cold plugger to condense it. Now let's come to the other class of sealer, which is a mixable bioceramic sealer, and this is BioRoot RCS from Septodont. It's a powder liquid form. You have the powder, and the company also gives you separate liquid for that. So this is the manufacturer's instruction. They recommend you to take 1 scoop of the powder. So always make sure you exactly take 1 scoop by leveling it with the help of a spatula. So I dispense it onto a paper pad, and following this is the liquid capsule. So you can break it open, and the manufacturer recommends 5 drops of liquid. So you cannot just use distilled water or anything to mix the sealer, because this is not just saline or distilled water. They also have certain other components like polycarboxylate in the liquid. So we recommend you to just use the liquid provided by the manufacturer here. So this is what they recommend. 1 scoop is to 5 drops, so that you get the right consistency. What we personally have observed, and also when I had discussion with people who use the sealer, they felt that this sealer is slightly thicker. The viscosity is little high. So some of the clinicians, they even recommend using Lentilo spiral to pack the sealer inside the canal, because they feel the viscosity is little higher compared to the pre-mixed injectable sealer. So this can also be now used in the second or the basic technique of obturation. You can coat it with your GP point 5 to 6 times. Following by that, you can do an activation. So the problem with this sealer is that the radio opacity is little low, and also the flow is less. So BioRoot RCS is from Septodont. You can see this is an obturation done with the BioRoot RCS. The radio opacity is less. It's mentioned also in the literature. And this is the Mark BC sealer that is manufactured in India. This also I experienced the same problem, and the radio opacity is very less compared to the pre-mix sealer. So this is the Cerasil from Metabiomet, which is a pre-mixed injectable sealer, and this was my first case when I tried it, and I just fell in love with this sealer, because the worry that I will not be able to get AH plus like obturation is now gone. So these sealers are as radiopaque as AH plus, and also they have an equivalent flow. So we all know that AH plus is considered as a gold standard for properties in terms of flow, film thickness, and your radio opacity. So this fulfills that. So it was easier, and I was also convinced to shift to this sealer. So this was a simple study that I did myself. I wanted to check the radio opacity of the Cerasil from Metabiomet, the BioRoot RCS, which is a mixable form, and the H plus sealer. You can see I have labeled it, and this is the resulting outcome. You can see that the Cerasil and H plus have very good radio opacity, whereas the BioRoot has a slightly inferior radio opacity. So to conclude, before we conclude, there is something that is very important we need to discuss, that is about the cost factor involved when you use the bioceramic in your clinical practice. So the injectable Cerasil is available as a 2 grams injectable syringe. It has great flow and radio opacity, as we discussed. The cost of this syringe is around 4,000 to 4,500. So tentatively you can use it for 40 canals. That's what I have personally observed, which means the cost per canal is 100 rupees for me. So you can simply think about different situations where you have cases with 4 canals, 3 canals. Sometimes we also have canals with just, teeth with just a single canal. So on an average, you can treat, I would say, 20 cases. So more than that, it's very easier for you to calculate it as per canal. So it's going to be 100 rupees per canal. Whereas the BioRoot RCS is available as a 15 grams powder liquid form. The drawback is that it has less flow and radio opacity, but comparatively it's economical compared to the Cerasil. The cost is around 12,500 Indian money. So you can use it for almost 150 canals on average. So the cost per canal is going to be 80 rupees Indian money again. So I think this will give you an idea about bioceramics, and when you want to shift to it, it's also very easy for you to calculate the cost involved. So though the bioceramic, the cost involved per canal or per case is going to be high, but eventually you're also reducing the cost of injectable GP or investing in a high-end obturation unit. So that's how we need to make a call when you go for a shift in your practice. So thank you so much again for subscribing to our channel and also watching me or following me on different social media platforms. For people who are new, these are the platforms where I share my content. And also I'd like to tell you that we do endo programs. We call it Endo 360, which is a complete endo workshop where we talk about different aspects of endo, and we do these programs at Virudhunagar, Chennai and Delhi. So this is the end of the video, and we are going to come up with more videos on bioceramic, different aspects like how do we clean the pulp chamber after bioceramic obturation, and how is it different, is MTA based sealers and bioceramic sealer different. All these questions are going to be answered in our further episodes. Thank you.